And I need to mention something here. The word dementia is like a general word. Many things come under that, like Alzheimer, Lewy body disease, and vascular dementia too. So dementia is like a common term that is defined as decline in cognitive function resulting in diminished ability to perform daily activity. Like when someone gets older, so there is a decline in his cognitive function, thinking, speaking, taking decisions, moving around. This is the decline in all cognitive function. Okay, under the word dementia, we have three main things. We have Alzheimer's disease, which is considered as gradually progressive disease. It takes time. It develops day after day. Okay, and also with Alzheimer, the cognition and behavioral functions are affected. We will see how now. The other type is what we call Lewy body dementia. Lewy, this is the name of a French physician called Frederick Lewy, and he is the one who discovered this Lewy body. It's a kind of protein different than the protein that is responsible for Alzheimer's disease. This is why it's called Lewy body dementia. And the last one is a vascular. It's about the blood supply to the brain. So when someone has any cerebrovascular disease that affect the supply of blood to the brain and leading to decline in cognition, it's a vascular dementia. So our main topic is Alzheimer itself, and this is what we focus on. So what is Alzheimer's disease? Alzheimer's disease results from accumulation of two things, something called tau protein clamp. Tau protein is like neurofibrillary tangles plus beta amyloid plaque. These are different types of protein. We don't need to know any details about them. And when they together are clamped together, it leads to a decrease in acetylcholine and an increase in glutamate. So briefly, Alzheimer's disease is decrease in acetylcholine and increase in glutamate. Okay, based on that, the medication used in treating Alzheimer, what will be the role of this medication? I need an answer, please. What will be the role of anti-Alzheimer medication? To do what?
Increase acetylcholine.
That's one. Yes. And what is the other function that anti-Alzheimer can do? Please participate with me, people, please.
Decrease glutamate.
Thank you, ma'am. That's it. So I need either to increase acetylcholine or decrease glutamate. Yes, just, yeah. Let's talk to each other so we can remember it. Okay, so we said that Alzheimer's disease have many like symptoms. So it might be associated with cognitive symptoms. Cognitive, it's about, when we describe the word cognition, it's about the ability of using your brain. So if someone has a problem with cognitive symptoms, it will be like memory loss, which is more common thing. Aphasia. When we describe someone that he has aphasia, it's like inability to use the language or impaired language ability. You see those people with Alzheimer's, they speak like, I went to a hospital, you know, something like that. Inability to use, he knows a word, but he cannot make a phrase anymore. And sometimes he needs to recall the word to remember. It's so difficult situation, but this is aphasia anyway. Also a kind of agnosia. Agnosia, remember it from the word recognize. When someone has agnosia, it means that he cannot recognize things, cannot recognize people. He might see one of his family member and he does not recognize him. He might lose the way to go home. These are agnosia. Also something called disorientation. Disoriented person, this is clear. And also apraxia. Apraxia is failure to perform a simple task or movement. For example, if you see the psychiatrist or neurologist, when they try to diagnose a patient with Alzheimer, they ask them to do something very simple. He asks the patient to point with his finger to his nose. He tells him, please touch your finger with your nose. Do you think this is something difficult for anyone? No, but for him, it's very difficult. He cannot touch his nose with his finger. I'm sorry because I didn't use the video for myself today, but next time I will do that. But I could show you how to, like, what is the meaning of that? He tried to touch his nose, but he cannot. Can you imagine that? This is what we call the apraxia, unable to do the simple tasks. And so the patient will be unable to do more complicated tasks. These are the cognitive function. Also, there are functional symptoms associated with the disease. What usually happens with Alzheimer patient? After some time, the patient can't go to the washroom alone. This is function. The patient can put clothes. This is one of the functions lost also. The patient might be unable to eat, to feed himself. He needs the help. This is loss of functional ability too. The last thing is what we call behavioral or non-cognitive. We talk about the cognitive already, which is memory loss, disorientation, aphasia, apraxia. The other one is non-cognitive. I'm sorry. Non-cognitive is like behavioral, which is regarding the mood. Usually Alzheimer patient will be depressed. Sometimes they develop hallucination and delusion. They are agitated. All of these are behavioral. So Alzheimer disease has three things to distinguish it: cognitive symptoms, non-cognitive or behavioral symptoms, and functional symptoms. Okay? Okay. So what are the risk factors for Alzheimer? Who is more vulnerable to have Alzheimer? Please answer me. Who is more vulnerable to develop it? Everyone can share with one thought.
Again,
Hello?
please the question. Again, please the question. I don't hear it.
The question is, like, what are the risk factors for Alzheimer disease? People with depression?
Age,
No.
old people?
Yes, of course, age, this is the first one, especially after 65 years. Alcoholic, yes, some are alcoholic, or people who has been using narcotics for a long time, people who has been benzodiazepine or anticholinergic for a long time, yes. What else?
Diabetics, hypertension.
Yes, diabetic and hypertension. And the reason is we said that there is a kind of dementia which is vascular dementia, because the diabetic people, the high blood pressure people, any cardiovascular issue might affect the blood supply to the brain, leading to vascular dementia. Exactly. Someone is saying the camera at Shaima is open. Shaima, close your camera.
Yeah, doctor, because I am walking and listen to you, sorry.
Okay, that's fine. Living alone, maybe. Sundowning. Sundowning, it's early to talk about it, Ahmed. Sundowning is the appearance of the symptoms when the sun, like at the sunset during nights. But we will talk about that later. Heat trauma, yes. Ahmed, why you are asking this question? It's too early.
It's written on the slide because I'm trying to look.
Oh, okay. Honestly, I'm not sticking to. I'm trying to give you the topic to, you know, just to cover it and understand it. Then we can go through the slides. You know. Yeah, sundowning is like the appearance of symptoms like during at night time. Okay. Family history of dementia. Yes, exactly, Noha, thank you. So I think we said almost everything. And also there is some evidence, but it's a weak evidence that female are more vulnerable to Alzheimer's than males. But this is like a weak evidence. It's not like a big evidence here. Okay. And we said depression, alcohol, and this stuff. Someone said depression in the beginning, correct? I believe so. Yeah.
Parkinson disease.
Parkinson leading to Alzheimer?
Yes.
No, I will not say this. I will not say it this way. I will say it like using antipsychotic for a long time might develop Parkinson-like symptoms, and then it might lead to Alzheimer's disease. Okay? Not everyone with Parkinson will develop Alzheimer.
Okay.
Okay. Not everyone with Parkinson will develop Alzheimer, but the chance of developing Alzheimer's disease while using antipsychotic is higher than having Alzheimer's disease after having a Parkinson. Okay. However, there are some cases that we will talk about during the slides for the patient, for this case, Armia, who has Parkinson and Alzheimer at the same time because they need a special treatment.
Okay, sir.
Okay, but we cannot deal with it as a main risk factor for developing Alzheimer itself. Okay, so the first one, we have non-pharmacological and pharmacological therapy while dealing with Alzheimer's disease. The non-pharmacological, can someone tell me how non-pharmacological will help a patient with Alzheimer's disease? In your opinion, how non-pharmacological therapy or CBT, cognitive behavioral therapy, will benefit a patient with Alzheimer's disease?
I would like to say maybe some sort of a protection for the person just to know what to expect. For example, one of the first things and the early things that would happen is the disability of driving and operating machinery. So maybe the therapy would just prepare him for what is coming as a precaution or as a protection. And at the same time, the family care and family support for him, maybe.
Exactly. So this answer is for the question, non-pharm, because what you are saying now is called education. It's education to the family and education to the patient. Yes, we need to do that to set up expectations about the disease and the progression of disease, about that we might need another family member to help the patient. But I'm talking now about CBT, cognitive behavioral therapy. Would it help the patient? I see your comment, Leah, with functional symptoms. No, because functional is about feeding, about going to the washroom. This is unrelated. So I think help the caregiver more. Yeah, it might for sure, but I'm talking about the patient now. Why would I give an Alzheimer patient CBT? Keep reminding him with the same thing. What do you mean? What do you mean, Samar? Like, you mean to avoid, to help him with forgetting things, to keep reminding him? He will forget again. Keep reminding him and he will forget again. Okay, let's tell you. We said that one of the characteristics of Alzheimer is behavioral symptoms, correct? And we said it's depression, it's agitation. This is why we use the CBT, because we need to overcome the behavioral symptoms. It's agitation, the depression, the low mood. This is why CBT has a big role in treating Alzheimer, because it focuses on the behavioral function or the behavioral symptoms, depression, agitation, low moods, okay? This is why we use CBT in that patient. Okay, He's telling here that how to measure dementia development. This is out of our scope as pharmacists. Functional symptoms are fast, and they use functional assessment staging tool. And for the cognitive, we have many scales here. One of them is mini mental state examination, and this is very common, the MMSE. And the other one is the MoCA, Montreal Cognitive Assessment. And also we have CAM, Confusion Assessment Method. Montreal Cognitive Assessment is one of the most common for many psychiatric disease, this one. But this is out of our scope as pharmacist. Okay. So it's telling you here about the stage. It starts with preclinical. It could happen to anyone, and it's related to aging, may not develop to other stages. Anyone, when he or she gets older, their function starts to get low. Their memory starts to be less. That's fine, that's normal. But it might develop to a mild case, which is impaired instrumental activity of daily living, like driving a car. The patient can still drive, but with many mistakes. It might reach to the moderate, which is impaired personal activity living, like going to the washroom, feeding themselves. The severe one, he needs assistance, someone to help with everything in life. The terminal one, unable to talk or speak or eat or walk, like it's terminal life stage. These are the steps. We don't need it also, but just for your information, there is no question regarding that might come in OSCE or MCQ or whatever. Medical exam, he says that CT scan, yes, we can do CT scan on the brain just to see where the amyloid protein are, where is the accumulation of protein in a specific area in brain, but EEG, it doesn't help. We don't need it here, but we can use it in epilepsy because we need to see the waves of the brain. What is the benefit of seeing the waves in Alzheimer? Nothing. But seeing it in epilepsy, no, we need it. And why we take many medications that work on sodium or potassium channel in the brain? Because it alters the waves in the brain. So this is why we might use CT scan for Alzheimer, but not the EEG. Also, we don't need that. Just for your information. CBT is not useful for the disease itself, not only for protection purpose to let the patient know what to expect and prevent. I will say that this sentence is not that accurate. I will say CBT is useful in behavioral symptoms like agitation, depression, and education, because education is not CBT. Education is something else. Education to the patient will help the patient to let him or her know about what to expect and how to prevent injury. Participation in intellectual activity was associated with a lower risk of dementia independent of heal. Sometimes the doctor asks the patient with Alzheimer to go to like concert to try to learn playing a new music tool, something like that, because it helped him to activate his brain. The learning process itself might activate some cells in his brain. This is why some doctor might recommend that. Some evidence suggests that physical exercise may be an effective intervention in the prevention of dementia. It will be mostly related to the blood circulation. The blood circulation is improved, and this is why we can improve the function of the brain. Okay, so forget about this for now. I will get back to it. I need to share something with you about the medication, the same way we did with antipsychotics, so we can remember it better. So share screen, dementia. Okay. Is this clear on the screen? Is there like a graph or a drawing clear on the screen now or not?
Yes, it's clear.
Okay. Yes, okay. Okay, thank you. So we said when we are going to treat dementia, we need to do two things. Either to increase the acetylcholine because it's low in Alzheimer patients, or to decrease glutamate because it's high in Alzheimer patient. These are the medication used to treat Alzheimer. Just remember this thing. What's happening here, I will tell you. So the first family that will increase the acetylcholine in the patient body is cholinesterase inhibitor. What's cholinesterase? So I have acetylcholine in my body, and it can be broken by either acetylcholine or butyrylcholine. And I have the enzyme acetylcholinesterase or butyrylcholinesterase. These are the two enzymes involved in breaking the acetylcholine. So if I make like inhibition to these two enzymes, I will give a chance for the acetylcholine level to be higher and to stay longer in my body. Okay? Okay. So the family that does that is called cholinesterase inhibitor, because these are acetylcholinesterase, butyrylcholinesterase. So the inhibitors work on both of these enzymes to give a chance for the acetylcholine level to be high. Okay, who are the members of this family? The first and the most commonly used one is donepezil. This is the most commonly used medication for Alzheimer. Then rivastigmine, then galantamine. These are the cholinesterase inhibitor: donepezil, rivastigmine, galantamine, and we will talk about everyone in details. Okay, I need someone to volunteer because I have some questions. This is how we can deduce the side effect of this medication rather than memorizing it. We can understand how these side effects happen so we don't have to memorize it. Would anyone like to volunteer so I can ask him or her?
Yes, sir. You can ask me if you want.
No, I will not ask you, Armia. I need someone else.
Thank you.
My pleasure. I'm sorry, I have been participating with everything, so I need someone else. Are you still there, people? Why no one is responding? Okay, zzz, zzz. Thank you, Muhammad. Zzz means sleeping. Okay, Mina, would you like to participate with me? Yes, we are here. Thank you, Susan. Okay, so Mina, I need you to help me in figuring out the side effect of this medication. So when a medication increases the acetylcholine in our body, what this will lead to?
Nausea.
Hello? So, yes, Noha, that's a great response. Yes. Acetylcholine, because nausea, exactly. What else? Yes, we are doing it now. Urine, wonderful. Vomiting, thank you. Yes, okay, thank you, that's it. So we know that acetylcholine is associated with the parasympathetic function of the body, like eating, digestion, bowel movement. All of these are acetylcholine function. Bradycardia, yes, Shams, thank you. So when acetylcholine increase in our body by the cholinesterase inhibitor, we will have this one, like vomiting here. Also, we will have like diarrhea. We will have hypotension here, and we will have low weight. Can anyone give me the rationale why we have like a decrease in our weight while having the cholinesterase inhibitor? How the high level of acetylcholine leads to weight loss? The nausea and vomiting. Thank you, Susan. This is one. Yes, thank you, Latifa and Susan. Yes, because diarrhea leads to loss of more fluids and salts from your body, and nausea and vomiting leads to what exactly? In addition to losing the supplement, what else will happen when you have more nausea and vomiting? your appetite will decrease, your desire to food will be less. This is why you will lose more weight. So we don't have to memorize the side effect now. Even if we have a question in the exam, now I understand what will happen if my acetylcholine is high. I will have diarrhea, will have vomiting. My heart rate will be less, bradycardia. I will lose weight. Okay, so it's clear here now what will happen. Also, one of the common side effects of high acetylcholine is insomnia. Please remember that because we will need it later. Added to the thing that you told me, which was all perfect, is insomnia. Okay? Okay, so this is the first family. Okay, the second family. What happens? What's happening here? These are the beta amyloid. These ghosts are the beta amyloid accumulating in our brain. Okay, so what happens is that when the glutamate work on the Nmda receptor here, it causes influx of calcium inside the cell. This is the brain cell, and this is calcium. The yellow ones are calcium. So when the glutamate level is high, it works on Nmda receptor here and cause influx of calcium inside the cell. By the way, the details I'm telling you now, you don't need it in the exam. I just would like you to understand what happens. You don't need that in the exam, but I need to help you remember the side effect in an easy way. So if the calcium increase inside the cell, the cell will explode because a lot of calcium, it will explode. Okay? Okay, Susan, thank you. So what I can do here, I don't work on the glutamate itself directly, but I block the Nmda receptor itself. This is how I can protect the cell from the action of glutamate. So the Nmda receptor antagonist is called memantine. Okay, memantine will block this receptor, prevent the glutamate from working on it, preventing calcium from entering here, and leading to keeping the structure of the cell. So no more progression of Alzheimer's disease because I'm protecting the cells of the brain now. Is it clear how the memantine will protect against Alzheimer's? Say yes, please. Say yes. One say yes, so I can go. Thank you. Thank you. Okay, now the question is, the function of the Nmda receptor, like this is a kind of inhibitory receptor. Okay, so when it's activated, you feel relaxed, you can sleep, you might develop constipation. So if you close it by memantine, what will happen? What are the side effects? All the opposite of what I mentioned. Against sleeping, you will be like that. You will be awake, insomnia. Wonderful, Leah. Yes, you will be agitated like that because you are active, hyperactive, and you will have diarrhea. Okay? So these are the medications used in treating Alzheimer. These are the side effects. Please remember this thing because it will remind you with everything. Okay? Okay, this is what we need here. Let's get back to, Armia entered. Okay, we will reshare the screen again. Okay, so for the functional and the cognitive symptoms, functional, we said like going to the washroom, toileting, like changing clothes, these functions, and also cognitive symptoms, we said about memory loss, about inability to speak, about inability to do simple tasks, we use the cholinesterase inhibitor. And because they are two different classes, with some patient we can use both. One of the cholinesterase inhibitor like donepezil, and we can add memantine. If you remember psychosis, because the first and second generation were working on the same receptor, we cannot combine them together. But here, cholinesterase inhibitor work on cholinesterase, and memantine work on NMDA receptor, so we can combine them if needed. So we use cholinesterase inhibitor or memantine, or cholinesterase inhibitor with memantine for the functional and the cognitive symptoms. The behavioral, it's depression, it's agitation. We said that we can use the non-pharm, CBT, but we can also, because it's depression, what to use? Antidepressants. Or we can use trazodone for sundowning and induced sleeping. This is what you were asking about, Ahmed. Sundowning is the appearance of the behavioral symptoms at night, like when the sun, like at the time of sit down, sunrise, I cannot.
Sunset.
Sunset, I'm sorry. It seemed that I'm me who started to sleep. Yeah, thank you. Okay, at the time of sunset, the symptoms of depression, agitation starts to appear. This is why we give trazodone, because it will help the patient to sleep. Okay, and if the patient has psychological symptoms, some hallucination or delusion, we can give him second generation antipsychotic. So why did I see here second generation antipsychotic, not the first generation? In addition to the thing that we know, but I need one answer. Why second, not first generation antipsychotics?
More selective and less side effect.
Yeah, because of what? Less side effect, like why? Why in this population? EPS. Okay, because because of we are dealing with old people, so the side effect will affect them to in a very negative way, like either EPS, either anticholinergic. All of this we need to avoid. This is why we go to the second generic antipsychotics, and if we use them, we don't exceed 4 months, because using antipsychotic in elderly patient is associated with death. Using antipsychotic in elderly patient is associated with death. This is why we don't use it for a long time. Okay? Okay, we will talk about each one of them now. So if we start by donepezil. Donepezil work mainly on the acetylcholinesterase. We said that we have two enzymes, acetylcholinesterase and butyrylcholinesterase. Donepezil work mainly on acetylcholinesterase, and it takes time to give full effect, up to 2 to 3 months. Okay, it takes time for the cholinesterase inhibitor, because we already have high levels of the cholinesterase in our body. So the anticholinesterase or the cholinesterase inhibitor take time to show effect, up to 3 months and sometimes up to 6 months. So we need to tell the patient to be patient about the results, to not expect quicker action. It takes action for the cholinesterase inhibitor. Okay, donepezil. We already discussed the side effect. It increases like the acetylcholine in our body. So we should expect nausea, vomiting, diarrhea. We should expect urinary incontinence due to the high level of acetylcholine. Also, insomnia, and we said this is very important to remember with all cholinesterase inhibitor, it's associated with insomnia, and also it might cause vivid dreams. Vivid dreams is associated with donepezil. Can anyone remind me about vivid dreams? What might cause vivid dreams of other medications generally, just to connect things together? Hello. Someone answer. BB beta blocker, wonderful. What else? Yes, ma'am. What else? Champix, varenicline, associated with vivid dreams. Okay. Beta blocker is correct, and varenicline also is associated with vivid dreams. Okay, thank you, Niveen. Donepezil has a lot of drug interaction. This is one of the main drawbacks about it. It might interact with the cytochrome B3A3, 3A4, 2D6. This is why we need to consider before giving it to the patient, especially for older people, because they have many medications, they are on many medication, to consider this kind of interaction. Okay, so at which level of the disease I can use donepezil, mild or moderate or severe? Donepezil can be used at any stage. This is what makes it like the golden boy of the cholinesterase inhibitor. It can be used for mild, thank you, Mina, yes, exactly, or moderate or severe. And this is why it's commonly used. You don't have to think a lot about classifying the patient. Is it mild, moderate, severe? Donepezil, okay? This is one point to remember. The second point is you need to taper the dose to decrease the withdrawal side effect. If the patient has been on it, never stop it abruptly. And if you are giving it to the patient, you need to do what? Start low and go slow. Usually the doctor will prescribe donepezil 5 milligram. You will find this prescription a lot. 5 milligram for 1 month. From the second month, give 10 milligram. We need to give it in like gradual way, either with increasing or decreasing because of the side effects. Imagine that you are giving donepezil 10 milligram, which is a high dose, to an elderly patient. So the patient will have severe diarrhea, urinary incontinence, which might lead to dehydration. We are talking about someone whose function is less. So can you imagine if an old man has diarrhea? He might suffer a lot with that because he cannot go to the washroom on time. So these are things that we need to consider. The third point about donepezil, we said that it might cause vivid dreams. Any recommendation, what can I do to limit that, to limit the vivid dreams of donepezil? I need your ideas about it, please. What to do to limit the vivid dreams? Leah, you are silent since long time, you and Latifa and Fufu. Please participate with us. Muhammad Wali, I think you already slept. You were sending me that you will sleep since a long time. What to do? Take it at AM. Thank you, Mina. Yes, Niveen, wonderful, that's it. Take it in the morning, it will limit vivid dreams, especially because we said that it causes insomnia too. So why don't take it in the morning? So we will limit insomnia, we will limit vivid dreams. You see, everything is connected with each other. To avoid insomnia or to limit insomnia and vivid dreams, take donepezil in the morning. Okay? Okay. Now, rivastigmine. It has its own characteristics too. So rivastigmine, we said about donepezil, it inhibits only acetylcholinesterase. Rivastigmine inhibits both acetylcholinesterase and butyrylcholinesterase. Okay? But the efficacy of this, like it needs shorter time than donepezil. We said with donepezil, it might reach 3 to 6 months even to give full effect. For rivastigmine, it's less, it's 1 to 2 months. Okay? And also it's associated with the same side effect, associated with acetylcholine, which is nausea, vomiting, diarrhea, GI upset, bradycardia. So it is the same. But for rivastigmine, it has a kind of a specific symptoms, which is anorexia. Anorexia with rivastigmine is more. Anorexia with rivastigmine is more. Can anyone define anorexia for me, please? What is the meaning of anorexia? It's like metformin. The other medications that, yes, thank you, Latifa. Thank you, Niveen. Thank you, Niveen, for being active with me. Thank you. So anorexia is the loss of appetite. So rivastigmine causes loss of appetite. And if we remember the side effect of the picture of the cholinesterase inhibitor, which was the weight loss, so for rivastigmine, weight loss will be more. okay, due to the anorexia. And remember that metformin too cause anorexia, okay? So what is the good point about rivastigmine? It's the drug interaction. We said about the donepezil, more drug interaction with cytochrome B, 3A3, 3A4, T2D6, 2D6, but rivastigmine, less, very less interaction. Okay, what distinguishes rivastigmine? It's indicated for mild and moderate, but not for severe. So if the questions come to you clear, a patient with severe case of Alzheimer, so I know that I will not select rivastigmine in that case, okay? The other point about rivastigmine is that it can be used for Lewy body dementia, which we said it's the formation of Lewy body, which is a different kind of protein than the tau protein and the beta amyloid. So if a patient, and to diagnose that, it needs a lot of tests and CT scan. Sometimes they need to take biopsy of the brain to decide the Lewy body. So once the patient is diagnosed anyway with Lewy body dementia, so rivastigmine is the drug of choice. Remember that rivastigmine is the drug of choice. Also, if the patient has Parkinson's dementia, this is what Armia was talking about. If you are still with me, Armia, you were asking me when we were talking about.
Sir, I am here.
Yeah, so when we were talking about the risk factor for developing Alzheimer and you said Parkinson, so this is a point I wanted to mention here. Like if a patient has Parkinson and dementia at the same time, the drug of choice is rivastigmine, okay? Okay, so also for rivastigmine, the point to remember is that tolerability to this medication, because it causes anorexia and it causes severe nausea and vomiting, is to take it with food. Taking it with food increase the tolerability, and this is important to remember about rivastigmine. And when the manufacturer finds that rivastigmine causes a lot of anorexia, a lot of nausea and vomiting, so many patients doesn't like it, what they did to solve this situation, what the manufacturer did. If you are a manufacturer, think about it.
The batch?
Thank you, ma'am. Exactly. So they made patch available. So patch is available, and also the liquid form is available from rivastigmine. But patch make it more convenient for many patients. Okay. Any questions so far? Nothing? Okay.
Sir, please, because I am lost the connection, I want to ask you a question. Maybe you said that when I out of the lecture, the donepezil, we can use it in the all stages, but not on all the time. I am right?
Exactly. You can use it in mild, moderate, severe, but
the rivastigmine in mild and moderate only.
Exactly. But if a patient has Lewy body dementia, what we will give him?
Rivastigmine.
Okay. And if a patient has Parkinson's dementia?
Rivastigmine also.
Exactly. So we need to differentiate between the stages of the disease or the severity of the disease and the different types of disease. This is point, which drug affect Lewy body dementia? You mean used to treat it? Is your question which one? I'm sorry, Mina is asking which drug affect Lewy body? No, Worset. Worset, antipsychotics. We will talk about that, Mina. Never use antipsychotic with Lewy body dementia. We will get to this point. Okay?
Sir, please, again, about the metabolism of donepezil. Donepezil metabolism with the cytochrome 3A14 and what else?
3A3, 3A4, and 2D6.
2D, yeah.
Okay.
But the rivastigmine?
There is no considered drug interaction that we need to worry about.
Okay, but it is less drug interaction than the donepezil, am I right?
Much less, much less.
Okay. How much it take for the rivastigmine?
1 to 2 months. 1 to 2
2
months.
months. And for the donepezil is 3 months. I am
3
right?
to 3 to 6 months. Yes.
Okay. Thank you very much.
My pleasure. Okay. So the third one of the cholinesterase inhibitor is the galantamine. And honestly, when you work at the pharmacy, you will find that you don't dispense it that much. You dispense donepezil a lot, then rivastigmine, especially the patch, Acetylcholine, then galantamine. But it's like very low, very few times that you will dispense galantamine. Anyway, so galantamine inhibits acetylcholinesterase, but it has another specific characteristic, which is working on nicotine receptor as an agonist. So this is just regarding the characteristic of the medication. We don't need it like deeply here now, but just to keep in mind, donepezil work only on acetylcholinesterase, rivastigmine work on both acetylcholinesterase and butyrylcholinesterase, but galantamine work on acetylcholinesterase and work also as a nicotine receptor agonist. Okay, what else about galantamine? Galantamine might cause the same common side effect, nausea, vomiting, diarrhea. Also, it might cause headache. We didn't mention headache in donepezil and rivastigmine, but it might happen to a higher extent with galantamine, headache, okay? So galantamine is still affected by the cytochrome B inhibitor, something like ketoconazole, for example, or quinidine. It will affect the level of galantamine. Can someone remind me about quinidine? It's a cytochrome B what? And is it inhibitor or inducer? Quinidine.
The quinidine is cytochrome 2D6.
Exactly. Cytochrome B2D6 inhibitor. This is one of the important things to remember. Inhibitor, yes, Latifa, but yeah, inhibitor for the cytochrome B2D6. This is why, for example, if someone is taking codeine, and we know that codeine need to be activated by the cytochrome B2D6, and he is or she is in quinidine, we need to think about that and to consider it. Okay, just try to connect things together. Anyway, I had a good, I think, a good collection of the cytochrome B different inhibitor and inducer in one page. I will send it to you so it can remind you easier about these details. Okay, galantamine is used in vascular dementia. So as we said, for Lewy body dementia and for regarding the rivastigmine, Lewy body dementia and Parkinson dementia, we give rivastigmine. For the vascular dementia, we give galantamine. But this is not like a very common thing to be mentioned or to come in the exam even. But just in case, galantamine can be used for vascular dementia. Galantamine can be used for mild or moderate, so no severe. So the only one used on severe cases is
donepezil.
Yeah. Armia, you are taking the mic all the time.
I am so sorry for that.
I need you to give the chance to our friends too. And please, my friends, please don't be sleepy, please, and thank you. Okay, so also for the galantamine, we might need to increase, but we still can give donepezil. Yes, Mina. The answer to this question is yes, but if it's a question in the exam with no restriction, like no contraindication for post galantamine and donepezil, and he is telling you that the patient has vascular dementia, which one you will choose? It's about preference now. Will you give galantamine or donepezil? Exactly. Thank you, Niveen. Yes, exactly. And yes, if it's, for example, severe case and vascular dementia, what we will give? Yes, thank you, Naveen. This is what I'm looking for. We need to look to the case as a whole, not a specific point, because we have other givens, other contraindications, other interaction that we need to consider. But yes, we are on the same boat now. Okay, so regarding galantamine, as we said, we might need to increase the dose, so it will be after 4 weeks. So usually, I'm telling you, if a doctor wrote donepezil for a patient, you will find that he wrote 5 milligram once daily for 4 weeks, then increase to 10 milligram. The galantamine, give a specific dose, it has many doses, then you will find that the doctor after 4 weeks increasing to double the dose. Why? To avoid the side effect which will happen. This kind of side effect will happen because acetylcholine is high in your body, so your body will respond by this side effect. So it's not something that we can avoid. But what we can do, we can start slow so your body will get familiar or will acclimatize with these side effects. Okay, we said about rivastigmine that it has a patch and liquid form. About the galantamine, it has ER formula because it's used twice, so the manufacturer made ER formula to be used as once. Yes, Naveen. Yes, titration period is 4 weeks for all of the cholinesterase inhibitor. Thank you. Although, just to be more honest about it, rivastigmine, sometimes the doctor can put the patient on the same dose for a longer time before increasing it. So I can say the answer to your question, titration period is 4 weeks for donepezil and galantamine, but it might differ in case of rivastigmine. I hope that I answered your question, just to be honest about the answer. Donepezil and galantamine after 4 weeks for sure. Rivastigmine, it varies. And a lot of factors contribute to that for rivastigmine because it's a patch, so the distribution of the drug is different. A lot of factors are here, so this is why it's not every 4 weeks exactly in case of rivastigmine, but we go high. I mean, in rivastigmine even, we start with a low dose, then we go high, but in a different duration of time. Okay, so regarding galantamine, we said that it's taken twice daily, and this is why they manufactured the ER formula to take it once daily, and the galantamine needs to be taken with food, the same as rivastigmine, just to avoid the side effect associated with it. Food will improve tolerability of both rivastigmine and galantamine. These are the cholinesterase inhibitor, and mostly we remember the side effect. The unique one was vivid dreams in case of donepezil and insomnia. Take it in the morning. When we talk about the rivastigmine, we said it's associated with anorexia, the same as metformin. This is why they manufactured as a patch. And regarding galantamine, we didn't mention a specific side effect other than headache, just to remember it about galantamine. Also something here, you might find that CTC said that about galantamine, it doesn't need renal dose adjustment, but actually, especially with the graph, if you see the medication monograph, you will find that the monograph said that we shouldn't exceed 16 milligram per day if creatinine clearance is between 9 to 60 milli per minute. This is like an added information. You might don't need it, but just in case. Under a specific number, galantamine need dose adjustment. Okay, but you might not use it. Use this information, I mean. Okay, the other one is the Nmda receptor antagonist, memantine. Where are we? Yeah, okay. So, Shams, you didn't mention memantine here, or you did? Seems you didn't. Memantine needs to be added here. Anyway, so regarding memantine, Memantine blocks the Nmda receptor, and also the efficacy is like the rivastigmine. I need to ask who didn't share with us. Fufu, are you with us here? Fufu is with us or not? Yes, okay, Fufu. My question for you is regarding rivastigmine. It starts to work after how long? Sorry, only for today I'm quiet. Oh, okay. So you are noisy in other days. That's fine. Okay, so okay. So you mean 1 to 2 months, not half month, correct? Yeah, okay. So I asked you this question just to connect it with the information I need to give here, which is memantine. The efficacy of memantine, which is a different family, is the same after 1 to 2 months. So it was only very long with donepezil up to 3 to 6 months. Okay, so memantine efficacy is after 1 to 2 months. Okay, memantine, we mentioned already the side effect associated with it. So if we can re-say it again, it's we said diarrhea, we said that alertness or insomnia, we said like agitation. Also, it might increase blood pressure. It might increase blood pressure, and also it might cause seizure, or we can say that it decreases the seizure threshold. So seizure is associated with memantine. It can cause the other things we mentioned like insomnia, headache, whatever. This is not important, but the unique about it, it might cause seizure, or it can decrease the seizure threshold, and also it can increase blood pressure. Okay, what else about memantine? So it's indicated for moderate to severe. Please, everyone, stay focused because I will ask a question here. So memantine is moderate to severe. Okay. Also, we need to make renal adjustment in case of memantine if creatinine clearance is less than 30 milliliter per minute. Also, memantine, I mentioned at the beginning of the lecture that it can be used alone, or we can combine it with other things. So it's common to see a patient taking donepezil and memantine for better control of Alzheimer. Okay. So we said now about memantine that it works on the Nmda receptor, and we said that it might decrease the seizure threshold. So we shouldn't use it if the patient has what? History of seizure. I cannot use it. If the patient has an issue with heart, because this medication increases the blood pressure, means that it might affect the heart rate. So it's illogical to give it to someone who has any issue with heart, just to keep that in mind. Okay, we said that rivastigmine, the tablet, is associated with nausea and vomiting. So sometimes what the doctor does, if the patient is suffering from severe nausea and vomiting on rivastigmine, but the rivastigmine itself is controlling the symptoms of Alzheimer, the doctor combine both memantine and rivastigmine together and decrease the dose of rivastigmine, so he can decrease the chance of nausea and vomiting, but control Alzheimer symptoms more. Is this point clear or not?
Can you repeat again, please?
Okay. So we said that rivastigmine has a higher chance of causing nausea and vomiting, correct?
Yes.
Let's say that the patient is taking 8 milligrams of rivastigmine per day. And this 8 milligram control Alzheimer very well. However, it's causing bothersome nausea and vomiting. So the doctor in this situation, how he thinks about it? He thinks that rivastigmine is a good medication, so I need to keep it, but at the same time, it carries a bothersome side effect. So how to control it? So giving the patient half the dose and adding memantine. So I give the patient half the dose to overcome the side effect and add the memantine just to compensate the loss of efficacy due to halving the dose. Like I'm trying to control the disease and avoid the side effect at the same time. Not only with Riva, because we can use it with donepezil, and we can use it for better control. And also if the patient has donepezil, has nausea and vomiting with donepezil on 10 milligram donepezil, we can give him 5 milligram donepezil and add memantine. But I mentioned it with rivastigmine, Noha, because nausea and vomiting with rivastigmine is high, and this is why they made the patch from it. Okay, but still it can be used. It's the same concepts. Nausea and vomiting are still associated with donepezil, but to a less extent than rivastigmine. So if a patient is controlled on donepezil, but severe nausea and vomiting, decrease the dose and add memantine. It is the same concept. Okay?
But sir, can I ask you some? Can I ask you a question, please?
Yeah, you can.
Okay, thank you. I read in the TC that is, and you can correct me. It is not recommended for the combination of the donepezil and the memantine. It is written like that. Not recommended the combination between the donepezil and the memantine.
Now I
Not
remembered why we removed memantine, because we got the same note raised, and Dr. Muhammad Sayed wrote that memantine to be taken, and then someone else said that the same thing in TC. It's saying it is not recommended. That's why we removed it.
Okay. Okay. So regarding your question, Armia, okay? The combination therapy for Alzheimer that you will find in practice is mostly rivastigmine plus memantine. Okay? This is a common, this is a common combination therapy you will see at the pharmacy. However, you will stay donepezil and memantine, but it's not common like the other one. So it's not recommended, doesn't mean it's forbidden or we cannot. Yes, you as a pharmacist can get away of that and don't recommend that. And anyway, you will not be questioned about something like that in the exam. But I'm telling you what happens in practice. The most common combination is memantine plus rivastigmine, and I already clarified why, due to the nausea and vomiting and this stuff. However, you might still see donepezil plus memantine. It's not favorable? Yes, it's not favorable. And what makes me talk about donepezil and memantine is when Noha asked me only with Riva. So the answer for this question, I cannot say for only, yes, only, because it's not only. It still can be used with donepezil. You know what I mean?
Yes, sir.
Mentioning the combination of memantine and donepezil was a direct answer for Noha question, because it still can be used. However, the more common is memantine plus rivastigmine, because this combination helps in controlling Alzheimer and at the same time limits the nausea and vomiting associated with rivastigmine. But the same concept, some doctors still use it with donepezil too.
Okay.
Okay.
Can I answer, if you please? Can you ask another question, please? Okay.
Yes, you can.
Okay. You said that because I am confused about it. If I have a severe case of dementia plus vascular dementia, we use donepezil or rivastigmine, because I'm confused in this.
No. So vascular dementia is treated by galantamine. This is first, generally.
Yes. Okay.
Okay. So your question is, if it's a severe case with vascular dementia, so the answer is donepezil, because donepezil is the only one for severe cases.
Okay. But also I read that we have to avoid the cholinesterase in general in the vascular dementia, because it is not neural disease. It's it is that you said it is a
vascular disease.
Yes. So now we and I read also we can use galantamine. So I am confused. We can use it or not, because in the TC said that by true word avoid the cholinesterase inhibitor in vascular disease.
You mean in vascular dementia or in vascular disease?
Sorry, in vascular dementia. Sorry, in vascular dementia, I have to avoid the cholinesterase in general for the pure. That's which written. Avoid cholinesterase for the pure vascular dementia. Consider that the cholinesterase inhibitor as a treatment option for a patient with Alzheimer with several vascular components.
Okay. So the answer for your comment or for question is galantamine is still used for vascular dementia. Because what is the other option you would like to use for vascular dementia? Memantine?
No, they said that you can optimize the blood pressure if it is the risk factor here. It's the blood pressure, for example. You can optimize the use of ACE inhibitor.
What if the patient already developed the disease? I already have a patient already diagnosed with vascular dementia. Okay, if I optimize the blood pressure medication, I will prevent the more progression of the disease, but I need to control what I have right now. Other than that, the patient will develop more and might die.
Okay.
You know, I have a problem and I have to deal with it, which is vascular dementia, which is like the blood supply to the brain was less at certain point and a kind of death to some cells, a kind of hypofunction to some cells have already happened. And we are talking about an older patient. If I optimize the blood pressure medication or the blood circulation medication, whatever, okay, it will help in preventing the progression. But how about the thing that happens in the brain now and I need to deal with it? Will I leave it?
No.
I need to deal with it, correct?
Okay, sir. Okay.
So what to give? Galantamine. What if it was a severe case? I will give donepezil. What if it was a moderate vascular dementia, a moderate case with vascular dementia? What to give?
Vascular dementia, moderate case, galantamine.
Yes. Okay.
Okay, thank you very much.
My pleasure. So I have just like simple question just to make sure that you remember that. So I will take Irini. You didn't participate with us since a long time, Irini.
Yes.
A patient with moderate case of dementia, what are your options to give? Irini? Hello? Oh, Irini disappeared. Are you still there? Okay, I'm not sure what happened. I will take Ihda. Ihda Hatem, are you there?
I am with you.
You are Ihda or Irini? I'm sorry.
Irini, in moderate
Yes.
case, you can use rivastigmine or galantamine.
How about donepezil?
Or donepezil.
You see? Yeah,
Yes.
deal with it like, okay. And how about galantamine?
Yes, we can use galantamine, donepezil, and rivastigmine in moderate case.
And memantine too?
Yes.
So everything, correct?
Yeah. Yes.
Okay.
Donepezil only in severe case.
Yes, ma'am. Thank you. Ihda? Ihda? Are you there? Not there. Okay. Susan, are you there? Susan? Naveen, are you there? Niveen.
I'm here, Niveen.
Hi, Niveen. So the question is, a patient with mild case of Alzheimer, which one of the medication you cannot give to him?
Mild donepezil.
Which medication you cannot give to him?
What kind of dementia is it?
Mild Alzheimer disease.
I mean, Alzheimer. Okay.
Yeah.
Which one we can't give?
Yes.
And antipsychotics. I don't know. Donepezil, galantamine, they all can work.
Memantine is only for moderate and severe.
Yeah.
And I said I will ask a question here, Niveen.
Yeah.
So if it's a mild case, don't give memantine.
Yeah, I mean all the all the cholinesterase inhibitors.
Oh, okay.
Mm-hmm.
Okay. Okay. Do you have any question to me?
No, all good.
Okay. Thank you. So these are the medication for Alzheimer itself. About the associated symptoms with Alzheimer, we said that the patient might have some behavioral change, might develop agitation and even psychosis like hallucination and delusion. What will we give the patient in that case? So antipsychotics, the second generation antipsychotics can be used if the patient developed agitation or psychosis in addition to Alzheimer's disease. But keep in mind that we are talking about someone who is old or even very old, and second generation antipsychotics are associated with death in elderly people. So I will give the antipsychotics only if the psychosis with this patient is severe, like they might harm themselves, they might harm others. At that point, on a risk-benefit ratio scale, I have to give them the antipsychotic for a maximum of 4 months just to control these psychosis and agitation. So keep in mind, antipsychotics are not used in these patients unless the patient has severe symptoms. And the other point is, if I'm going to use it, only for 4 months because it's associated with death in elderly people. The other point that is crucial, very important, is that the patient who has Lewy body dementia cannot use the antipsychotic. This was your question, Mina. Who cannot use or which medication should be avoided in Lewy body dementia? It's antipsychotics. Yes, yes.
Yeah, it's risperidone.
Yeah. Okay, and we usually use the second generation antipsychotics. Okay, the patient might have the behavioral symptoms, depression and low mood. So we need to give him what? Antidepressants. Which one is used? The SSRI are used, but also tricyclic antidepressants might be used. Okay, and it has been studied because tricyclic antidepressants, risperidone, Latifa. The answer is risperidone. It's commonly used as antipsychotic for the patient with this psychosis and agitation while having Alzheimer. However, you still can use something else, but risperidone is commonly used. So here, the antidepressant used is SSRI. However, tricyclic antidepressants are still used. Can anyone deduce why? Although we said that we need to avoid the tricyclic antidepressant with elderly. So can anyone answer me why tricyclic antidepressants are commonly used with elderly patients in depression associated with Alzheimer? What do you think? What do you think? Okay.
Yeah, maybe it decreased the fall.
The what?
The fall of the patient.
But the second generation antipsychotic, the tricyclic antidepressants will still cause falls more than the SSRI. Correct? Yes, yes. Yeah, yes. So the tricyclic antidepressants. Thank you, Fufu. Yes. Thank you so much. Thank you so much. So, first of all, the tricyclic antidepressants were invented before the SSRI. So, when they made clinical trials on Alzheimer's disease, they have to use the tricyclic antidepressant because SSRI wasn't available at that point. SSRI is considered like, or are considered new medication. So the clinician have more experience with tricyclic antidepressant in depression in case of Alzheimer's disease, but they have to decide to use the least anticholinergic ones, which are desipramine and nortriptyline. So you will find it commonly given. Aventil, which is nortriptyline, is given to a patient who has been on donepezil. And the reason for that is to control depression associated with Alzheimer's disease. You will find this prescription a lot, Aventil and donepezil. And when you think why the patient is taking that, the patient is old, why the doctor is giving that, then you will remember, because more studies were done for tricyclic antidepressant in depression in case of Alzheimer, and the doctor is trying to give the less cholinergic one, the one with less cholinergic side effect, which is nortriptyline or desipramine. Desipramine is not commonly used in Canada, so it's nortriptyline. Okay, and it gives a very good control of depression during Alzheimer. The last one used is trazodone, and we use it to manage agitation and sundowning. We said sundowning is the appearance of behavioral symptoms at sunset. So trazodone will improve the sleeping, at the same time decrease the sundowning. Does anyone have any idea if benzodiazepine can be used for like agitation or in elderly people with Alzheimer? Can we use benzodiazepine?
No, with elderly, no.
Yes.
Yes, we can. But very specific medications.
I'm sorry, you are answering what?
The benzodiazepine?
Yeah. And also the side effect like falls or these things, we need to avoid them. This is why they didn't make enough studies on it, because you cannot try benzodiazepine on an elderly, otherwise you might kill them. Okay. I see a kind of questions here on the chat. I'm trying to catch what happened. I'm sorry, I'm confused. What is the question again on the chats? Because I see someone asked something and someone replied. What was the question, sorry, on the chat? I'm lost. I don't know what is the question, or there is no question now, so I don't have to respond. I don't know. Anyway, I will complete until someone write on the chat. Okay, so is there a specific time that I should stop the Alzheimer medication? Is there a specific point at which I should stop? This?
Yeah, no.
Okay. Okay. Okay, what other than death? TCA will not deteriorate dementia because of anticholinergic side effect. Yes, ma'am, you answered the question already. We said that Alzheimer's disease happen due to like decrease in acetylcholine. Correct? And the tricyclic antidepressant has anticholinergic side effects. What is the question, Naveen? Please ask the question without the answer so I can answer it. I'm confused like that. Yes, dementia happens due to the decrease in acetylcholine. I'm sorry, Latifa, 1 second, so I can answer Naveen, so I can go to your question. Naveen, can you call, please? Can you talk with voice? It will be easier to understand.
Okay, I'm with you. I'm just asking, dementia happened because decreasing in the acetylcholine, right?
Exactly.
So when we give the tricyclic antidepressant, it gonna deteriorate the case.
Exactly. This is why we said doctors prescribe nortriptyline and disipramine because it has less anticholinergic side effects.
Okay, okay. So just to treat the depression.
Yes, disipramine and nortriptyline. And we said that they depend more on them because the study on them are more than the SSRI because they are older. So there was a more time for them to be studied. Okay?
Okay, good.
Okay,
Yeah,
thank
perfect.
you.
Thank you.
Yeah, so Naveen is asking, tricyclic will deteriorate the case? Yes. Tricyclic other than nortriptyline and disipramine, something like amitriptyline, for example, it will deteriorate the case. Yes. So Latifa, you had another question. I'm sorry. You were asking if benzodiazepine are used in elderly? Yes, I was asking, and the answer is no. There are no enough studies on that, and the benzodiazepine are avoided due to their many side effects that might affect the elderly people. Okay.
Dr. Ayman, if it's okay with you, just to discuss that with Sayad, because he totally said something the opposite, and we have the LOT, the LOT. As you see it, it's the next slide actually. The lorazepam, the oxazepam, and the temazepam, and we have chosen it. Yeah, no, go back. Yeah, we have chosen those agents just in cases of severe agitation.
Okay. Okay. Let's answer this question while we are here. So lorazepam, oxazepam, temazepam, generally speaking, are the preferred agent of benzodiazepine if you need to use them in elderly, in a case like severe insomnia. You don't give like other things like flurazepam, for example, because it accumulates in body. So if you are going to give something, you give the lot for insomnia. But for Alzheimer, we try to, and a patient has agitation, we try to control it with other things like disipramine, nortriptyline, even SSRI. To go to the benzodiazepines, this is like a last choice if the patient is not responding to anything. So yes, we can use it, but this is not an option for us as pharmacists to recommend, for example, to a doctor. You know what I mean?
Yeah, it's clear now. Thank you.
Again, lorazepam, oxazepam, temazepam are the preferred benzodiazepine to be used in elderly. But for what case? For insomnia, for example, yes. But for agitation associated with Alzheimer, no, I will not go for them until I try disipramine, nortriptyline, citalopram, escitalopram, until I try trazodone with escitalopram. If no response at that point, and also I might use the risperidone, I might go to the benzodiazepine, but it's not a first or second or even third choice at all. It's a last resort to tend to use. Okay? Is anyone confused about this point? Okay. Where are we? What are symptoms to measure drug effectiveness? Okay. Decrease repetitive questioning, because it means that the patient's memory is improving to some extent. The patient can focus. Decrease sundowning, especially when it's trazodone. The symptoms, the behavioral symptoms are less after sunset. Less memory loss, it's associated with less repetitive questioning, and also less insomnia, okay, and less disorientation. Okay, so these are the symptoms, and we can see that the medication is working when we see improvement of this medication. Cardiovascular disease are risk factor of dementia. We already discussed that. Hypertension, diabetes, our colleague here helped us and said that already, that's fine. NSAIDs could affect or decrease the risk of dementia. Anyone have an idea why NSAIDs will decrease the risk of dementia or might decrease the risk of dementia? Any thoughts about it? It's simple and direct. Why ibuprofen will decrease the risk of dementia or might decrease the risk of dementia? Hello? Might prevent the vascular one. Thank you, Naveen. You thought right in the thing. Yes, because it might cause blood thinning, and blood thinning means that there is a bigger chance of delivering the blood to the brain, so limiting the chance of vascular dementia. This is how you see it, Naveen, correct? Thank you, ma'am. Exactly. But I cannot depend on that fact. Like, I will not give NSAID for a patient, for example, for vascular dementia just to limit it. But I know a piece of information, which is NSAID might decrease the chance. Okay, so one of the things we need to mention here is when I should stop giving the patient medication. So our friend Noha helped us by saying if the patient died. So other reasons, what, Shams? You are raising your hand. What would you like to say?
I'm sorry, just I have a very fast question about regarding the NSAIDs. You said ibuprofen. What about aspirin and the other NSAIDs?
It is the same, ma'am. They are called thinning of blood. Just I took ibuprofen as an example. But the reason is because all of them cause thinning of blood.
So it would be another like beneficial thing for aspirin in elderly to maybe it would be cardiovascular disease, of course. Yeah.
So
Sorry,
you would
thank
like,
you.
for example, if an older patient is taking regular medication and you would like to give him aspirin just to help him?
No. But I'm saying it's another benefit for a patient who's already taking aspirin. That
But there is
it
no
would,
strong evidence about that. This is like a kind of theoretical results by the clinician, but there is no clinical trial, because to judge something that we can use this for that, we have to make a clinical trial and we have to have a significant results. Okay?
Okay, thank you.
So there is no clinical trial that was done to use aspirin, for example, in elderly people with vascular dementia, and then they were following or monitoring the improvements. But because the theoretical knowledge say that NSAIDs will increase the blood thinning or decrease the blood viscosity, so the chance of developing vascular dementia will be less. But what do you think is the percent of that? 1%, 2%? So it's not a significant result that we can depend on. You know what I mean?
Yeah, I totally understand. Sorry, carry on.
Thank you, ma'am. Okay, so we need to stop the medication if the patient is not taking it regularly. Some elderly people are resistant to medication. So if someone refuses to take the medication, okay, I cannot do anything. I have to respect autonomy of the patient, even if the patient is harming himself. When a side effect is uncontrolled and the patient can tolerate it. Thank you, Noha, exactly. So I think this is better than death. Thank you for your positive contribution this time. Yeah. Okay, a patient has developed bothersome side effect with no improvement. No need to give the patient the medication. We mentioned this point, when should I stop giving the medication here? Because I'm dealing with very old one, like end of life. So you might need the patient at his like last few days or last few months to live his life freely. No need to give him medication to give him side effect with improvement. This is why this point is mentioned here, not in other disease. When should I stop giving the medication? Okay, what else? Even if the patient doesn't have any side effect, but at the same time, there is no improvement after like 4 or 5 months and you tried many medication and there is no benefit, okay, it's time to stop the medication. Okay, the last thing that is used in Alzheimer, and this is Shams will be more appropriate than aspirin, is ginkgo biloba. Because ginkgo biloba improves the blood circulation and also increase blood thinning. So it can play a positive role in decreasing Alzheimer. It increases blood flow and decrease viscosity of blood. However, there is, yes, memory enhancer, exactly, Mina. However, there is no strong evidence about it. Like, you will not find that a doctor prescribes ginkgo biloba for a patient with Alzheimer. It's just like a complementary medication, like most herbal and vitamins. It doesn't have like a clear rule, a significant evidence that I can say, okay, I can use ginkgo biloba here. They think that because it increases the blood thinning and enhance the blood circulation, it can improve. But for me as a pharmacist, if I have been asked, will it help? The answer is, it might. Okay, because you cannot give a positive answer, it will, unless you have a significant result from a trial. This is why we say donepezil, memantine, galantamine, because they tried it on patients, on thousands of patients, and there are results. But ginkgo biloba, no. But anyway, it's still better than aspirin. Okay, ginkgo biloba, it's contraindicated if patient is taking what? Help me, please. If someone is taking what, you cannot give him or her ginkgo biloba. Hello? Hello? Who cannot take ginkgo biloba? What if someone is taking clopidogrel? Can you give him ginkgo biloba? Oh, thank you. Yes, yes, aspirin. I cannot remember. Or warfarin. Yes, exactly. Anything that work on blood. Coagulation, anticoagulant, like antiplatelet, all of this, you cannot give us choices. It's already answered, Mina. Yes, anticoagulant or antiplatelet, exactly. Or someone who is taking NSAIDs for a long time, because both will increase the chance of what? Answer me, please, from the CVS. If you are taking many medication that might cause blood thinning, what the patient might develop? Yeah, bleeding is a general thing, but what exactly? Hemorrhagic stroke. Yes, yes, Summer, that's it. That's it. Yeah, this is what I'm looking for. Yeah, GI bleeding is a case, yes, but what I'm concerned more about is hemorrhagic stroke. If a patient is taking many medication, more than one medication, that might cause blood thinning. Okay, also ginkgo biloba, if you take it with ergotamine or caffeine, it might cause something called subarachnoid hemorrhage. Okay, it's the same way because it works on blood thinning, so it might cause that. And also ginkgo biloba decrease the seizure threshold. So we need to take care of that. So the question to Armia. Are you still there, Armia?
Yes, sir. I am with you to the morning.
Okay. So what was the medication that decreased the seizure threshold?
Okay, in general or in the dementia. In the dementia is the memantine. Is a memantine.
Okay.
Memantine, the one with decrease the seizure threshold. In general, the propion can cause risk of seizures for patients like that.
Yeah.
You hear me? Hello?
Yes, I hear you. Bupropion decrease the seizure threshold. That's correct. Also,
yes, and ginkgo biloba, it is natural drug, causes that also.
Yeah, because I'm talking about ginkgo biloba now, so it decreases the seizure threshold.
Yes.
So I believe this is the end of Alzheimer's disease. I need to truly apologize for you for taking long time, but I loved to have a conversation with you like that and to discuss. So I hope that it was beneficial for you, and I think I will make more time management next time. Okay, you said it interacted. Naveen, we are talking about ginkgo biloba, correct? Yeah, and it interacts with ergotamine and acetaminophen and the caffeine, and it might cause hemorrhage while taking them with ergotamine, acetaminophen, and the caffeine. Also, ginkgo biloba was found to increase blood pressure if taken with thiazide. But, you know, it's not something that we need here, but they found although hydrochlorothiazide, for example, although hydrochlorothiazide alone will decrease blood pressure, but they found that if you combine ginkgo biloba with hydrochlorothiazide, it might increase the blood pressure. And it's unknown why this happened. And with ergotamine, caffeine, and acetaminophen, it caused this hemorrhage. It's a case called the SAH, S-A-H. It's a subarachnoid hemorrhage, and it's a kind of life-threatening type of stroke. It's still in brain. This is why ginkgo is not like, don't give it to anyone while you are in the pharmacy. Although it's common, many people use ginkgo biloba, use it for memory, even men use it for sexual dysfunction, like the people who do exercise and sport use it, but just keep in mind while you are giving it that if this patient take acetaminophen, if it's take pseudoephedrine, for example, and he take high dose, this patient might develop this subarachnoid hemorrhage, stroke, and it might lead to death. So don't make it an easy decision to give ginkgo biloba for anyone.
Sir, you said that aspirin, caffeine, acetaminophen, and pseudoephedrine?
No, it's ergotamine, acetaminophen, and caffeine. However, because pseudoephedrine has like the vasoconstrictor effect, so if a patient take it in a high dose and take something like ginkgo biloba, there is a chance of developing a stroke. This is why, like the main points, I need to see that while you are a pharmacist, don't think that it's an easy decision to someone, okay, I hear that ginkgo biloba is something good. Yes, it's good alone, but you need to make sure that is the patient taking Tylenol, because the patient will be mostly taking Tylenol. It's fine if he's taking 1, 2, 3 tablets daily for like 3 or 4 days, but how about the people who take Tylenol like candy? Many people do that. But Tylenol alone, it might affect their liver. But if you add like ginkgo biloba to someone taking 8 or 10 tablets of Tylenol, no, you put him at that point at a bigger danger of developing stroke. So just to remember that.
And the aspirin and the caffeine, I am right?
Yes.
What about the codeine? It is okay or not?
Codeine?
Yes. Or it is caffeine?
Caffeine, not codeine.
It's
codeine is
caffeine, yeah,
unrelated
okay.
to that.
Okay. And the bardo, it is not matching with clopidogrel. I am right?
What
Any blood
bardo?
thinner.
I'm sorry, what bardo means?
Okay, with the clopidogrel.
Yeah. Yeah, because anything that cause blood thinning, clopidogrel, antiplatelet, any antiplatelet or ticagrelor, any antiplatelet or anticoagulant, don't give ginkgo biloba at all. Never give it. Otherwise, the patient will develop bleeding and might develop the hemorrhage stroke.
Okay, thank you very much.
Okay, I will meet you everyone soon with something in psychiatry too. And I'm sorry, I'm the one who will be giving you endocrinology, diabetes, hypo and hyperthyroidism, and also many topics in a cardiovascular system. So I'm sorry for that. Try to tolerate me, but I will try to make more time management. But I really liked talking to you and like having a conversation with you. Thank you so much for today, and have a wonderful night. And I'm here anytime. Anyone have a question, please message me and I will reply at my first convenience.
Thank you very much.